Hello, I'm Clarice Warner, the girl with the pearls, founder and education director of the Professional Reimbursement Network, where coding education is key. Let's talk outpatient laboratory, pathology, and radiology coding. The first quarter 2017 coding clinic reminds us that physician documentation still reigns supreme. As coders, our jobs are guided by the documentation in the medical record. In the outpatient world, it is primarily based on what the physician documents. Physicians come from various specialties. Often overlooked is the documentation of radiologists and pathologists, who are physicians. If there is physician documentation providing a definitive diagnosis, that is what you code. Let's review some examples. A patient undergoes outpatient surgery for removal of a right breast mass. The pre- and post-operative diagnosis is reported as breast mass. Pathological diagnosis is fibroadenoma. How should the hospital outpatient coding professional report this? Previous coding clinic advice has precluded us from assigning codes on the basis of laboratory findings. Does this same advice apply to pathological reports for the facility? The answer is the facility should report code D24.1, benign neoplasm of the right breast, for the fibroadenoma of the breast. Previously published coding clinic advice has warned against coding for laboratory results alone without physician interpretation. However, the pathologist is a physician, and the pathology report is confirmation of his or her tissue analysis and can be used to provide greater specificity when coding outpatient encounters. The next question. A patient presents to the doctor's office with a complaint of fatigue. The physician orders a complete blood count, or CBC. The CBC reveals a low hemoglobin and hematocrit. Should the lab report the presenting symptom fatigue using code R53.83 or a diagnosis of anemia using code D64.9? The answer is the laboratory, whether independent or hospital-based, should report codes for the symptoms because a physician has not interpreted the results. You would assign code R53.83, other fatigue, unless the lab calls the physician to confirm a diagnosis of anemia. A referring physician sends a urine specimen to the cytology lab for analysis with a diagnosis of hematuria, code R31.9. However, the cytology report, which is authenticated by the pathologist, revealed bladder cancer. Although the referring physician assigned code R31.9 hematuria unspecified, the laboratory coded C67.9 malignant neoplasm of the bladder unspecified. For reporting purposes, what is the appropriate code assignment for the laboratory and the referring physician? The laboratory should report code C67.9, malignant neoplasm of the bladder unspecified. It is appropriate to report the carcinoma in this instance because the cytology report is authenticated by the pathologist, which serves as confirmation of cell type similar to a pathology report. The referring physician should report code R31.9 hematuria unspecified if the finding of the cytological analysis is not available at the time of code assignment. If the cytology report is available, the referring physician should report code C67.9, malignant neoplasm of the bladder unspecified. And our last example, or last question, a patient presents to the hospital for outpatient x-rays with a diagnosis on the physician's orders of questionable kidney stone. The abdominal X-ray reveals bilateral nephrolithiasis with staghorn calculi. No other documentation is available. Is it correct for the facility to report code N20.0 calculus of the kidney based on the radiologist's diagnosis? The answer is it is correct for the facility to report code N20.0 calculus of kidney. Code to the highest degree of certainty. The radiologist is a physician, and when the X-ray has been interpreted by the radiologist, code the confirmed or definitive diagnosis. The official guidelines for coding and reporting diagnostic outpatient services section 4K state, for outpatient encounters, the diagnostic tests that have been interpreted by a physician and the final report is available at the time of coding, code any confirmed or definitive diagnosis documented in the interpretation. So there you have it. The physician's documentation of a definitive diagnosis guides our selection of the correct and accurate ICD-10 diagnosis code. Thank you for watching. If you have found value in this information, please like, share, and comment below. Remember, be safe, be kind, and don't wish for it, work for it. See you next time.